I'd like to thank Chris for giving me this opportunity. And I'd like to thank everyone. And I thought it was an 8-minute presentation, but it has been extended to 15 minutes. It's a collaboration of 4 cases which I have done in last 5-6 years. So as the name suggests, it's fishing in the coronaries and it's equipment loss. So case number 1, 50-year-old male. He is hypertensive, dyslipidemic, presented to ER with worsening chest pain after regular workouts. ECG suggestive of ST elevations in the inferior segment. STEMI was activated. Angio was immediately done. Straightforward. Triple vessel disease. The culprit was RCA PLV cut off from the proximal segment. So decided regular radial approach. So Xion blue wire closed easily into the PLV. Lesion pre-dilated with 2.5 into 15 mm non-compliant balloon and easily stented with 2.75 into 24 mm DS. Went ahead with post-dilatation 3 into 12 mm NC balloon, and that's when I thought the procedure has ended and the balloon was partially inflated and it didn't come out. And I just tried to pull it, and eventually even the wire came out. But I was little lucky that the flow was still there. So then I rewired the RCA, put in 2-3 more wires inside, wires crossed, swirled for 30-40 seconds, and continuing the swirling, eventually I got the balloon out. Case number 2, again a mid-distal LED lesion, straightforward. It was pre-dilated with 2.5 into 12 mm NC balloon. There was little bit of dog boning there, so went up to higher pressures. It opened up, took a long stent, 2.75 into 44 mm, stent placed. The post-dilatation in the proximal and mid part of the stent was done by 3 into 15 mm NC balloon. For the distal part, we decided to take a 2.75 into 8 mm NC balloon, and during post-dilatation, the balloon again broke. So 3 more wires again put inside, but only 2 could pass, but still again swirling, little bit of flow impairment there in the LED. But eventually we could swirl it and take the balloon out eventually. Case number 3, the same case, we re-engaged it, rewired it, post-dilated again with another balloon, and achieved a decent result, and we finished it there. Case number 3, patient for angio normal. As we can see, the OM is occluded. Tried to engage the right coronary, but it couldn't be engaged with the JR or the Tiger. So eventually had to take a AL. Tried the AL again and again, and eventually the AL is broken again. So now what to do? The snare, we tried to find it. The technician is finding the snare. He's not getting the snare. So we made a handmade snare and tried to catch it with it till that time. And we were unsuccessful. And eventually the catheter came up, and the technicians are still looking for the snare. Someone came up with a crazy idea ki let's take a JR and try to hit it, and actually I was hitting the AL with the JR, tried to wire it and take a balloon, and it was also not possible. So went ahead, eventually got a snare out. The snare went in, and after a few attempts, eventually caught the AL, and the AL eventually is out. This is the last case. Just finished with the LCX, stenting the LCX, and final shoot. Just saw that the wire looked little different. Tried to pull it, the wire was broken. So again, tried with the same technique. Again, 4 wires, 3 wires, went in, continuous swirling together. We thought we are successful. Now again, this time the wire is missed in between. It is lost. So it is stuck again in the mid LCX. So again, went in, Again trying to swirl it. Eventually we thought, okay, we are in the catheter. So, okay, happy it is in the catheter. Saw on the table that the wire is still not there. Only the broken wire is not there. One injection and the wire is again back. But we were lucky enough to have it in the catheter. So eventually had to balloon trap it, and with that it eventually came outside. So that again, then the catheter is engaged with a diagnostic catheter. Check shoots are taken. Everything looked fine. So case is ended there. So take home message: such thing happen. It happened more in India and more in the peripheral parts of India. So we have to be calm. We need to know the techniques, and multiple wire technique is one which has been used by me most of the time. Snare has to be available. If snare is not available, you should know how to make a snare. It's very easy. Then there are other techniques like passing a small balloon distally and trying to pull that out, but I think it's little risky because you may eventually push the things away. If you are lucky and the shaft of the balloon is in the catheter, then you can always trap it, but you never know how is it there or it is not there. Because if it's not there, then you again are pulling and pushing and you may again displace it. And the last one is always remember you have surgical friends to take that out. Thank you.
Brilliant. We're right. Where do we start?
Sir?
Where do we start? So much to discuss. And I think we should bear in mind that if you are reusing equipment, which you do in India, you're more likely to get fractures. Do you want to go back to the first case?
Yes, sure, sir.
So did the balloon didn't come down? Is that was the first part of that? So why does a balloon not come down?
I'm coming there, sir.
So
Sir?
what happens that the balloon doesn't come down? Go back to case one.
So that's a food for thought. When your balloon does not deflate. Now that's not what you presented this because your balloon shaft fractured.
Yes, but that's the
But
second
that's
part.
the
of it.
second point.
That-
The
that's the
first
sec-
point is
Balloon is not deflating. Is
why
the
did
first
the
point.
balloon not deflate?
And I think you have to have a little think here. Why is this happening to you? Because these are, you know, I think it's the same things feeding in. The first thing that happens is you get a kink in the shaft.
Yeah.
And the kink in the shaft then sets up a one-way valve.
One-way valve happens.
So the contrast can go in, but the contrast won't come back. So whenever you've got a balloon not come down, it's because you've kinked the shaft, and you will have kinked the shaft in this situation. Look at how your guide's out into the aorta, and this will be interaction with your guide at the aorta-wall junction and hinging off the shaft. So you kink the shaft, your balloon won't come down, so you've set up a one-way system. The next part is you try and remove it, and you break the shaft.
Correct. That's what happened, sir. And I was...
The same thing happened in your second case?
No, sir. In the second case, the balloon is deflated. And it's
But
slow.
you still had a shaft fracture. So again, you have fractured the shaft, and that's why the balloon won't come out. Now, it might be more likely because you're reusing equipment.
Correct, sir.
But if you wait for your balloon to come down, and you don't have if your guide well seated, and you're putting the correct amount of tension, usually this happens when you try and retract the balloon before it's fully deflated. And your guide comes in and kinks your shaft. That's when this happens.
Sir, right now, in this case, when I actually when I didn't even have a pull there. I just like to take it and it's out.
I
I think it's a
out.
king.
It's
It's a
already-
king balloon. It's an overused balloon, and it broke.
The only thing...
One point I want to make: when your balloon is not getting deflated, don't pull it.
Yeah.
What you can do is cut the shaft. Take a guide Zilla or guide liner, cut its strip and push
Burst
it, and then burst the balloon and then pull it out. If you pull it, it's going to break at the junction between the monorail segment and the shaft. And generally, that's inside the guiding catheter most of the time. And you can just use a balloon trapping method.
And the same with the wire. One of the things you can do is you put an intravascular imaging catheter along, and if you've got equipment inside the balloon or inside the guide, you put up a balloon. So if you think of your force case where the wire's embolized, you've got them back into the guide, bring up a balloon, a 2.5 balloon, and pin all that equipment inside the catheter and take everything out.
Yeah, most of the times the balloon breaks up, so 99% of the times you'll be able to take it out by just balloon trapping in the guide catheter. And if I break a wire, I'm going to call it to swirl because I've never been able to swirl wires inside.
Sometimes with the swirling is a great technique where you put down multiple wires and you need to get them into different branches. You got to put them into different branches to fix them. But sometimes you will entrap your stent, and then you bring the wires back, and you're bringing the stent with you.
So there are a few questions. I put them down here. Why did the balloon not deflate? And that is maybe a one-way valve.
One-way valve due to the.
So what is your steps to be taken if the balloon does not deflate?
If the balloon does not deflate, we can have different techniques to have it broken. So one is we can first try to take a 50 ml syringe or a bigger syringe to try to negative it if it is possible. If that doesn't work, then we can take a smaller catheter inside with a slit cut there and try to burst the balloon. Third one would be we can take a hard wire and try to burst the balloon, and the last one would be just to take it to a higher pressure and burst it completely.
I'll suggest a simpler technique. Take an old Guidezilla,
Yeah, and push it
chop
again.
the end, allow the few shall I say
Wire.
points to come out, and use that to burst the
Burst
balloon.
it.
Okay. So that is probably thing which works best because it abuts. We have tried time and again by trying to take hard wire, a CP12, reverse end of a wire. We never get it with a microcatheter or without.
You can actually take a pacing stylet
Yeah.
along the shaft where the contrast goes and try and puncture the valve. So if you take
But the
a
best
pacing
way, we have, unfortunately, we've also had a few of these occasions, is not so many,
Even
but
the-
not so quickly because we've had them, 5 or 10 years different, separated in time and space.
No,
But one of the easy ways is to take an old guide liner, allow the stillets to come out, and use that to perforate.
Could we go back to the case? Could you show us the guide? That's because snaring is very important. The third one.
Third one, yeah.
Yeah,
And the third one is a NY catheter, but it was old catheter near expiry.
I was-
So that was really surprising for me.
I was going to just make the point that if you see where your position was, it's often easier to snare in the subclavian than from the femoral. And there was a stage where, can you play go back to the slides? Can you play the?
Which one, sir?
Can we show the angiogram,
For the,
Broken catheter. Show the broken catheter.
the broken guide?
this is the,
Yeah. So can we see it up on the screen?
oh, it's not,
Okay. So see on the third one.
yes.
If you go to the next picture where you're trying to snare it from the leg because you're in the leg, if you had come down from the right wrist, the right radial, you're coming down straight at it.
Straight into it.
Yeah, it's much easier to snare it from the right radial because the aorta is so. And you tried this with the redwood.
Thing which I have written. Firstly, you must know, everybody here must know the differences between a balloon shaft fracture and a wire fracture. Because very often a wire fracture you can even stent it and leave it in the vessel wall. But a balloon shaft fracture normally has a significant length.
Correct.
And that is length adequate for it to be trapped by another
The-
balloon to be able to be brought out. As long as it is deflated. The other thing is about how to pull the wires.
At least we should take maximum amount of wires there, and you should take the
So one of the tricks.
torquer. That
One
put it
torquer.
into the- One torquer, put
One
all the
torquer.
wires in, and then
So-
roll
so-
it, and even while you have to pull it when you are completely rolling continuously. If you
remember,
stop the rolling,
you
it will
can't
again
do it
leave
with multiple torquers. All the wires have to come into one torquer. And lastly, your homemade snare was not as well made as some of the other homemade
Correct,
snares.
correct.
I would suggest that you take a right
I had a
dominant
video
catheter.
of that.
Are you
put
better
it.
practice the snares?
Yeah, we've kind of got a PhD and some patent rights on not making homemade snares.
So were you able to pull out from the sheath this catheter, or did you take out the sheath while pulling?
It came into the sheath, sir. It
Because-
came into the sheath.
So for pulling out through the sheath, you have to hold it at the end of the catheter. That's what you did actually. It was
Yeah,
at the tip of the
I
catheter.
didn't do it, sir. It happened.
So if you do it at middle point, it will get
Yeah,
folded,
yeah,
and many
then
times
you
it
have
breaks again, and it won't come through the sheath basically. So that is a problem.
But some great retrievals, actually, some great, And then here, I think it is worth putting intravascular imaging.
How much time did all these happen? All these cases? They
This
don't-
has been over 5 years. 5 years.
5 years. Then it's okay. I was wondering if it was very frequently.
No,
Then there's something.
These have been
happening here.
clubbed.
Then there's something happening here.
The last one is the latest one. I think it's. The date is.
I know, as we say with the broken wire, the issue is you may have a filament which comes up into the guide, you know, and then you take your guide out and the filament remains in the aorta. So I would image it, and if there's any filament inside the catheter, pin it with a balloon and take everything
Yeah.
back.
So the Gaia wires we all use for CDO interventions, and the Gaia wires are, we know that when they get in between calcific spots, when we are trying to traverse them, and that is why the technique of using a Gaia wire is not the standard technique which we are using, a penetrating, or so you need to deflect the Gaia wire. And if it gets trapped and you pull it, it elongates and it can break. And that can be a nidus for future activities. And that is why the Gaia has now been replaced by the Gaia Next, so that the breakages in Gaia wire don't occur. So anyway, these are interesting things to know, and great presentation.
Thank you, sir. Thank you. Thank you very much.